Alright. Hi guys, my name is DJ Griner, and I know you guys should know me, but I am doing my presentation on Ida Jean Orlando. She's a nursing theorist from way back in the 40s, 50s. Most of her stuff came about in the 60s throughout the 90s, and yeah, my presentation. Now, when you're doing this, while you're watching this, the TV, because of the theme, it's a white background and it doesn't show the words. So I suggest either printing my PowerPoint that's up or looking at my outline, just keeping something up, however you want to do it, because you're not going to be able to see the presentation when I go through this. I will, and I'll explain everything. But I suggest having something there to follow along. Just if I don't say something or you want to jot something down, make sure you get it down that maybe I don't have. Okay? Because not everything I'm going to say is written up on it. All right. All right. Go to the first slide. All right. Now, Ida is an Irish-born American, and she was born August 12, 1926. She got her nursing diploma from New York Medical College on the Flower Fifth Hospital School of Nursing in 1947. Received her BS in Public Health Nursing from St. John's University, and in 1954 she got her master's in Mental Health Consultation from Columbia Teachers College. Most of her job that she did consisted of teaching. She taught at Yale for 8 years and was also the director of the graduate program in mental health psychiatric nursing. During this, she's also had two publications. Her first publication is The Dynamic Nurse-Patient Relationship, Function, Process, and Principles. It's an NLN Classics in Nursing Theory. That was in 1961. And she also did The Discipline and Teaching of the Nursing Process, an evaluative study in 1972. You're going to see me come in and out because I got to click a button to move from slide to slide. Now, her theory framework, she's known for the deliberative nursing process, and I know all of us have heard of nursing process. You assess, diagnose, you plan, then you implement, and you evaluate the patient. It was all about patient-centered care. She was all about getting the patient involved in their own care, not just the nurse doing whatever they think is best as well. And she is considered also a middle-range theorist, and I'll get more into this after I go through all her different definitions. Now, she believes the nursing care must be patient-centered. The role of a nurse is her actions should be based on rationale, not protocols. The nurse is supposed to base everything off the patient's needs and their immediate situation. The nurse isn't supposed to just go off of what her overall diagnosis might be from the physician. There might be immediate situations, say the patient might be dehydrated. She is supposed to do a deliberate nursing process to fulfill that duty. So she's gonna set aside everything else and create a specific process just to fix the dehydration. Some other things she said about nurse is nursing is independent of the medical profession because the actions toward patients, because of their actions towards a patient's immediate experience. And that is true because, say, a doctor, it's going to diagnose, but they're going to take into account various different aspects. While a nurse is looking after them daily, they got to look after their daily needs, and they have to figure something out for the immediate time being. If they're experiencing pain at the moment, they're going to focus on that pain, not curing the diagnosis that might take inevitably a month or maybe even longer or maybe less time. And nurse, like I said, nurse must always focus on the immediate situation. Now, she considers health being measured through distress. Distress being a patient's uncomfortable situation, per se. And the degree of distress is highly influenced by the length of distress. A patient can start feeling distress at a moment, but if it's prolonged because the nurse is not taking care of it, it's going to only increase in distress, which is only going to make things worse for the patient. And distress is also defined as being felt when a patient's needs are not fully met. So let's take a distressful situation might be if a patient has, say, a red blotch on their leg, and that ends up being, say, a bed sore. Say it's on the side. They're going to be feeling distressed to that. Say they might be in there, say, for a heart problem, and they had heart surgery, but at the immediate moment, the biggest problem is the sore leg. And so the patient needs that need met. And the nurse is supposed to act on that, not just focus all on the heart surgery, making sure they're okay with that. They're going to focus on that duty, create it, go through the whole process, and try and get that fixed. Now, for her, like I said, it's all patient-centered. The patient is the most important aspect of the care. It's not about the nurse in almost any manner. The nurse has a say, but the patient is the ultimate factor. And they need to base that off of a patient's interactions and behavior. By that, the nurse is supposed to interact with the patient. It doesn't have to just be on a medical basis. Talk to them about their life. See, there could be another stressor in their life causing something. And that could be weakening them, that could be causing a distress in their body, that could be causing an entirely different problem. And the nurse is going to act on the interaction they have with the patient, just like the patient's going to interact on the reaction and the interaction that they have with the nurse. It's a back and forth agenda right there. And you cannot create that care plan without the patient. You're going to assess them, you're going to figure things out, but you're going to get subjective data as well as objective. And for that, just to describe that means, objective data is what you're going to observe. That's everything you're going to see without patient help, but you got to get subjective to see patients like pain tolerance. See what the pain says about what they're experiencing. You got to take that into account because then you're going to create a diagnosis, and then when you go to plan everything out for the healing, you got to include the patient because you can't do something out of the patient's comfort. That could only cause more distress. You want to make sure the patient has a say in everything with their total plan of care. So that when you implement everything, the evaluation is going to look positive instead of negative. Now, Ida's very similar to Patricia Benner in the fact that she doesn't really look at environment almost like Nightingale, where Nightingale is all about having a very clean environment. It's all about keeping everything sanitated for the patient, and she more focuses on the situation that the patient is in. And the nurse is supposed to create a comfortable situation when the patient is in distress. And as we went through distress, a comforting situation could just be whether maybe a patient, like say a patient with dementia, maybe they need some familiar items from home because they're in a completely different area, different sounds, they're not in their house, they're not in the room, they're not familiar with anything. You gotta make them a little more comfortable with their environment. And a situation is based on a patient's behavior, and the nurse should only reflect that current situation. So they can worry about the environment overall, but if a patient's needs are not met due to a certain situation, the environment needs to be adjusted for that situation to help that. If you help that and maybe another problem occurs, you adjust it to that situation. You gotta find some ground to balance that to make sure you get an ultimate environment that's gonna make the patient comfortable. All right, now we're going to get into the deliberative nursing process. And as you know, the nursing process is assessment, diagnosis, planning, implementation, evaluation. She bases on three concepts: the patient's behavior, the nurse's reaction to that behavior, and then the nurse's action. When looking at that, the patient behavior could be, it would just be the distress. Any distress the patient is feeling, that is going to be the behavior the nurse is going to look at. They're going to react to that. And they're going to talk with the patient about it. They're going to react with the patient's going to react back to how the nurse reacts. Once all that's in, the nurse is then going to take action to try and fix that distress and create a comfort for the patient. And again, it's all about the patient's immediate need. I know I sound like a broken record with saying this, but you gotta just focus on the immediate situation, not the long term, not what happened in the past, but what's going on right now. It's the immediate need of the patient that must be centered for the attention. And nurse-patient relationship is really going to determine it. If you don't have a good communication with your patient, it's not going to be a good experience for the patient. It's not going to be a good experience for you. You might not get things done because the patient doesn't trust you. The patient doesn't want you doing certain things. You got to listen to that. If the patient doesn't want to take the medication, you can't force it down their throat. I mean, that is illegal. But if the patient likes you, they trust you, they're going to be more inclined to listen to you. They're going to want to trust you with that. But if you can learn trust for them and trust that they know what they're doing with themselves a little bit, you might be able to be influenced by them a little bit just as much as you're going to influence them to get better. It's going to be an overall positive experience instead of a negative experience because they're already going through a lot of distress on having to even be in the hospital with the current medical problem they may be facing. Also, be sure, before I go to the next slide, I have a picture here. This kind of represents everything. You have the picture. It's going to show action goes to perception by the patient, just like the action of the patient is going to go to the perception of the nurse. That's going to create thoughts and feelings that are going to create an ultimate experience to get the distress removed. Now, for case study, I didn't actually find a case study. I came up with a clinical situation. I had been experienced with this when I was at my previous school up in Lone. So we learned a lot about the nursing process. And I'm kind of going along the line from what I mentioned with a bed sore from bed rest. And we go, say a patient is dealing with soreness in the sacral area. They've been on bed rest. So as a nurse, you're going to start the nursing process by assessing the area. You're going to look at it, you're going to see a blotch of red skin and diagnose it as impaired skin integrity related to elongated bed rest as evidenced by soreness of the sacral area. And I'm sure we all learned this. Basically, you're just going to look at it, you're going to see that there is very red skin, clearly irritated. So you got to clearly just focus on that because that's a serious moment. Because if you let that go, that can turn it into stage 2 pressure ulcers, which is going to start opening skin. And you don't want to get to the point where it's going to get to stage 4, where bone's going to start showing, tissue's going to be dead. You can't let it get to that point. So if you can recognize it when the skin's still intact, which is very red and irritated, that's perfect. Because then you're going to plan with the patient on maybe some ways to get them out of bed. Maybe they're supposed to be in bed rest. If that's the case, then you want to plan things on rolling them over every couple hours. Make sure they're not laying on one area at a certain point. Make them understand that that's necessary. But maybe if they're not on bed rest for a long time, they're able to get out of bed, they're able to move, but the patient just simply doesn't want to move. Try to talk to them, figure out some activities they can do that they're actually able to participate in. Try and get them out of bed, get them in a wheelchair, maybe even get them walking if they're capable of walking. Do different things to get them to not lay on that area with so much pressure for such long periods of time, because that's the only thing that's going to make it worse. And to get them off that pressure is going to make it get better. Once you talk to them, figure out what the patient likes and figure out what you think is going to work best, you can correlate something and create a plan. Once you create that plan of how to heal it, try and get an evaluation day within about 3 days. 3 days should be good. Check the area, see if the area is getting worse, then you got to redo everything, reassess it, create a plan, and do something to try and make it better again, because that means it's clearly not working. But if it is getting better, it's working, and you want to continue the process, continue making it better, and continue to get the distress removed. And then that is it. These are my references, and thank you for listening. I know this is a different experience. Usually everyone else has been performing this, but if you guys had any questions for me, don't feel free to email me. If again, watching this, I know may be different. In case you didn't miss anything, you can watch it again if you'd like. I also, again, the PowerPoint is going to be posted. I have a little outline that gives a general overview of what you really need to focus on. But if you have any more questions that you wanted to know about IDA, I'd be more than happy to answer them. You can email me or just talk to me in class at any point. I can even give you guys my phone number if you absolutely need that too. However you need to contact me. But yeah, thank you for listening, guys.